Okay, let's get started. Welcome to Tired of Being Tired, Talking Strategies with sleep expert Dr. Shelby Harris. Let's Talk Menopause is a national nonprofit organization changing the conversation around menopause so women get the information they need and the healthcare they deserve in midlife and beyond. My name is Donna Klassen. I'm the co-founder. I'm also a clinical social worker. Today, we're joined by Dr. Shelby Harris, an expert on sleep and menopause. And we'll dive into the talk shortly, but first, a few housekeeping items. Our monthly menopause talks are central to our education efforts to ensure women receive evidence-based menopause information from the leading experts. We have a rich library of over 30 talks on our website. So if you'd like to go deeper on any topics, go to our website at letstalkmenopause.org/talks. All of our menopause talks are intended for informational purposes only, not as a substitute for professional medical advice, diagnosis, or treatment. And a big thanks to our sponsor, Bayer, to make these talks happen. A few other housekeeping items. We've disabled the chat, and we'll only be using it to provide you with relevant links. So check there for links sporadically. Please ask your questions in the Slido app. You should see it, the prompt to the right side of your screen, inviting you to participate. That's where you can ask questions. We will do our best to answer all of your questions. They are really important to us, but we also appreciate your patience if we don't get to yours. And also remember that we cannot answer unique personal medical questions. So please try to make the questions a little bit more broad. There will be a brief survey at the end, and that is really instrumental in helping us improve our offerings. And we will also send a recording of the event. We will send out a recording of the event to anyone who RSVP'd. That will be later in the week. So if you miss any of this or you want to send it to a friend, we will be sending you that. So I would like to introduce Dr. Shelby Harris. Dr. Shelby Harris is a licensed clinical psychologist in private practice, and she specializes in cognitive behavioral therapy for anxiety, depression, and sleep disorders. She's a board certified in behavioral sleep medicine and previously directed the behavioral sleep medicine program at Montefiore Medical Center's Sleep-Wake Disorder Center. Dr. Harris holds a doctorate in clinical psychology from Yeshiva University and is a clinical professor, associate professor of neurology and psychiatry at the Albert Einstein College of Medicine. She's a recognized expert in evidence-based non-pharmacological treatments for insomnia, circadian rhythm disorders, and other sleep issues. And she's published extensively and is frequently featured in major media outlets, including the New York Times, the Wall Street Journal, Oprah Magazine, and on the Today Show and Good Morning America. Welcome, Dr. Harris. Really happy to be here.
Thank you for having me. I'm really happy to be here.
Great. So let's just start out with like an overview of what are the sleep issues that you see in women during midlife.
So there are three main areas that we see. The first is insomnia. We see that all the time. And that's, I think, the thing that a lot of people will be very vocal about, right? Why do I always seem to wake up at 2 a.m? So insomnia. The other thing that really doesn't get spoken about as much, but we're talking about it a little bit more, is sleep apnea. So it's pauses in breathing, because I think a lot of people think that it's that snoring, that really loud kind of noise that's happening. In women, it's usually much more subtle, but we see it really frequently in perimenopause and menopause, and it's just pauses in breathing, very subtle snoring. And then the other one that doesn't get talked about is restless leg syndrome. So restless leg is really, it can be very related to hormonal changes. We see it a lot during pregnancy, and then we see it a lot again at this time of life. And it's really, it can look like insomnia because you have trouble falling asleep, but it's more because you can't move, you can't stay still. You have to keep moving your legs, your arms, and it can even be in your trunk. The name is a bit of a misnomer. And you can have all three too. You can be lucky and have all three. It doesn't mean it's one or the other.
Oh my gosh. So is it, wow, I did not know that restless leg could be seen in other parts of the body. That's so interesting.
Yeah, the name is a misnomer. They have like newer terms, Willis Ekbom, like they have different terms for it or different names for it, but everyone still calls it RLS.
Got
And
it.
yeah, some people will just say like it's like their arms or their trunk. It's like, but they get missed all the time because they just think they're antsy or anxious. But it really, if it gets worse as the night gets closer, it's probably RLS.
Got it. Okay. So insomnia, is that just trouble falling asleep, or is it all three, like trouble falling asleep, trouble staying asleep? Because I guess those are the two. Is it
So it's either, I mean, the staying asleep, yeah. So it can be any or all. So trouble falling asleep, trouble staying asleep, or waking earlier than you want.
that?
And it has to, the big key for insomnia is it has to create a problem for you in your daily functioning or your
Okay.
daily life. So you could just be annoyed by it happening in life, and that's a problem. That's fine. But if you're not bothered by it, you're fine with it, you actually technically don't meet the criteria for insomnia.
Okay. So yeah, that leads me to my second question. So what is the criteria for insomnia?
So that's that trouble falling, staying, or awakening earlier. It has to happen. Here's the key: at least 3 or more nights a week for
Okay.
1 month to be considered short term or acute, as we'll call it, or 3 or more months to be considered chronic. Now, the thing that I like to stress to all my patients is that remember, it's 3 or more nights a week.
Mhm.
So I think in our society, a lot of the messaging is about perfection and having perfect sleep. And that's actually creating insomnia in a lot of people because they're putting so much pressure on themselves. When in the reality, I don't sleep perfect every single night. I have a bad night here and there. It's about brushing it off and knowing that you're still within normal limits. But if you start getting closer to 3 or more nights a week where you're just not happy with your sleep, that's when you might want to see someone for some help.
Right. Yeah, got it. So why does insomnia develop, and why do we see it more in perimenopause and the whole menopause, postmenopause?
So we see insomnia develop for three different, I always call it like this perfect storm of issues that really happen. And when we talk about the perfect storm, there's the biological, right? So when you hit perimenopause and menopause, there's all these hormone shifts. And a lot of times when you have the sharp drops in estrogen, progesterone, when you see those sharp drops, that's when a lot of times the anxiety, the hot flashes, the insomnia can really hit. And then you have the biologic, then you have this psychological stressors. So women tend to have higher rates of anxiety and depression in comparison to men in general. But then the big piece that gets missed that people don't talk about enough is the social part. That's the third part of the storm. Women are more, I mean, just busier and more stressed than ever. And
Mhm.
so a lot of us are having, I know myself included, like having babies later in life. And so we get put in this sandwich generation a lot of times. So like I mean, I have a teenager and an almost 10-year-old, but I also have aging parents that I'm having to take care of as well. So you have that sandwich generation. And then also we're working outside the home more than ever. So we have all these stressors that are happening there. It's not like you can come home and then just quiet down. You're just constantly on. So all those three things kind of work together and create insomnia.
And what about hot flashes? I mean, because I know that, it's said that, hot flashes um, can wake people up, or you can wake up prior to hot flashes.
Yeah. So a lot of people will wake up. I mean, it's the hormonal shifts that are causing it a lot of times, but people will often wake up before they actually are feeling hot and having the sweat. So it's something to keep an eye on. And then the other thing I always do stress to people is if you're waking up and you're having a lot of sweating, um, sleep apnea, like I said, it's very common in women in perimenopause and menopause. And sleep apnea can cause a lot of those symptoms or exacerbate hot flashes, exacerbate nighttime sweating. So it's definitely something to have evaluated.
How do you know if you have sleep apnea? Like, do you have to be evaluated for it to
You
get?
ideally, so if you're feeling like you can have insomnia and sleep apnea together a lot of times, but if you feel like your sleep is not restorative, if you feel like you're really dragging a lot throughout the day, if any significant other is noticing any pauses in your breathing, not overt loud snoring, if you're noticing any heartburn, if you wake up with headaches in the morning, that's a really big symptom. If you have a headache in the morning a lot of times and then it gets better as the day goes on, it might be that you actually have apnea at night. If you use the bathroom a lot at night, which can be a symptom of many things, that can also be sleep apnea. A lot of these things can overlap with menopause symptoms too, right? We talk about weight gain, we talk about feeling tired. But if you just feel like something is off with your sleep, it's best to just mention it to your doctor. And if they keep brushing it off, I would suggest finding someone who will listen because it's ignored all the time. Even with women that you would think are like fit and thin, the rates are the same as men when we hit perimenopause or when we hit menopause.
Wow, I did not know that. Learn
Yeah.
something new every day. Okay. So talk to us about cognitive behavioral therapy for insomnia.
So CBT, a lot of people will think CBT for insomnia is similar to like CBT for anxiety and depression, if you've heard of that before. But the idea is of CBT for insomnia, it's a little similar, but pretty different overall, in my opinion. So what it is a very short-term, evidence-based treatment for insomnia. And it's been around for since like I would say like the late 80s. It's been as a treatment, like a package treatment since the early 90s. But what it is kind of a package of different treatments for insomnia that we know work pretty well. And when we put them all together, it works even better. And it is, believe it or not, it's evidence-based and it's the gold standard treatment for insomnia ahead of medication for most people because in 4 to 8 sessions usually, sometimes
Wow,
even shorter, people start sleeping better. And you know what? They don't need medication long term.
that's great. That's amazing. And do
So
you see patients for 4 to 8 sessions?
I have some patients I've seen 2 or 3 times. Yeah.
Really?
And I
That's
only see them, I typically, I mean, it varies based on the provider. I typically see people every other week, and then I'll have like email check-ins in between. But it's very short term. Like when I was at Montefiore in the sleep clinic there, I had some patients that I would see once, twice for really, really, really short-term treatments. So it really varies. I find the longer amounts of time that I'll need to see people for, or if there's a lot of, as we all say, comorbidities. They have a lot of other occurring issues that are going on that are getting in the way of really being able to adhere to it as we'd want them to initially. So maybe depression, anxiety, things like that. Doesn't mean you can't do the treatment. Or the other reason that it might take longer, a little bit longer, is if you're on like sleep aids, and you need to taper off of them. It's kind of like we do it slower and we kind of readjust every time we reduce the medication.
Okay, great. So give me some of the details about
Yeah.
CBT-I. What is it?
So C, cognitive, B, behavioral. Okay, so I always start with the B part first, so the behavioral. Um, and like I said, it's like different treatments that were all packaged together. But I tend to, when I work with patients, not everyone needs everything. So I kind of am more fluid with people. So the first thing we always think about is sleep hygiene, right? And I'm confident that almost every single person on this talk has heard about sleep hygiene at some point. And what that is really, you think about it, it's limiting caffeine, limiting alcohol within 3 hours of bed, limiting, we're trying to have a wind down time, right? It's all that stuff. We're not exercising right before bed. All of those things are good. But here's the thing with it is that it's important to follow sleep hygiene as not rigidly, but as best as you can. But the reality is that actually is not usually the thing that moves the needle for most people who have insomnia. So most people with insomnia is like, I've tried all the things. They've really just tried sleep hygiene. That's the control group in most studies, believe it or not. So if someone keeps giving you sleep hygiene, just know that whatever. But it's nothing else is going to work if you're drinking a 2-liter bottle of Diet Coke right before bed.
You
So that's
have to you have to adhere generally by sleep hygiene, and then you go deeper into
the
CBT-I.
way I always talk about it is it's like dental hygiene. My colleague Rachel Mamber once said this. It's like you want to brush your teeth and floss to help prevent a cavity. But if you get a cavity, brushing and flossing isn't going to make the cavity get better. You've got to do other things, but you're still going to brush and floss. It's the same sort of way to think about it. So then we have two other parts of the behavioral module. So one is what we call time in bed restriction, or you might see it as sleep restriction. And what that is, it's counterintuitive. So you were asking how insomnia develops. A lot of times what we're doing is common sense stuff. Like, I'm really tired. I'm going to try to go to bed earlier tonight and hopefully I'll catch more sleep or I'll sleep in or I'll try to nap. Those are the things that actually the common sense is what's making our insomnia worse. So CBT is hard because it goes against common sense and what family members might say to you to do. So if you're someone who is sleeping, let's say, I'm just making up a random person, 6 hours a night, but you're in bed for 8 hours because night after night you're hoping that you're going to get that beautiful 8 hours and catch up because you're so tired. But on average, you're only getting 6 hours. What we actually do is limit you to 6, maybe 6.5 hours in bed. So you pick a wake time, it's the same time 7 days a week. That's a hard thing. And you go to bed usually a lot later. than most people are doing. And what happens is after a few weeks of doing that, your body starts to learn, oh, she really is like means business. I got to get that sleep, but in this window. So you fall asleep faster, you stay asleep longer, or if you wake up, you go back to sleep a lot faster. It's better quality and it deepens your sleep. And then over time with the provider, you learn when to every week go to bed earlier and earlier.
And you do
So
it really gradually, like you do it like 15-minute increments, something like that?
exactly. So you essentially what you're doing is you're tricking your body to meet you where you are, or sorry, initially you're meeting your body where it's at. So you're saying,
Yep.
okay, I give up. I'm not going to do the 8 hour in bed thing. I'll give you 6. And then once you start sleeping better, then we start tricking your body into giving you more sleep by going to bed just a little earlier every week or so. So you get to a point where you start to learn, okay, I went to bed too early. Now it starts falling apart. That's too much. So it's quality first, then we work on quantity. I'm not going to lie, it's a very hard treatment module. And if you're going to work with someone on it, work with someone who's really familiar with it because they can modify it for you too, especially if you're on sleep medications. Like you don't want to just like take an Ambien and then go to bed only for 6 hours and then have groggy issues in the morning. So you want to work with a provider if you can. So that's the next part of the behavior. The third part of the behavioral modules is called stimulus control. Stimulus meaning bed. You're controlling the bed for sleep and sex. So the pop quiz that I would love to give most people here, yes, definitely behavioralsleep.org, great place to find someone. That's in the chat. So the pop quiz I give everyone is I want everyone on this kind of this talk to think when you think of your bed, what's the first thing that you think of? And if sleep is not what comes to your mind and it's more like frustration or rest, then you have trained your body that the bed is for things other than sleep. So the idea is, and you might have heard it elsewhere, it's like people will say 20 minutes in bed. If you're not asleep, get up and go do something else. I don't like 20 minutes because we don't want you looking at a clock at night. So it's really when you just notice your brain's really busy or you're frustrated, that's the sign that you should just get out of bed, go sit somewhere else, and just do something to pass the time. It's not about forcing sleep to happen, sitting out in the dark and getting yourself really bored. That's not it. It's just a placeholder. Do something that just passes the time, that's mildly relaxing and calming. And then when you get sleepy, you go back to bed. And if you don't get sleepy, and guess what? The morning comes, it's a bummer, but you start your day and then the next night you'll probably sleep better. It's really hard, but it works really well. So that in combination with the limited time in bed is very effective for most people. So stimulus control. So those are the behavioral parts.
Okay.
And then the other part is the cognitive. So that is a little bit, I don't do that with every single person, but I do it with a lot because it's if you're someone who says to yourself, like, I have to sleep tonight or else XYZ is going to happen tomorrow, or you feel that sleep, people are talking about sleep anxiety more and more. It's not actually a diagnosis, but people talk about it. If you start feeling really like worried about sleep or you're really rigid about it, you probably need to do some cognitive therapy work about it. So it's about teaching people that it's not always black and white when it comes to sleep, that you can have a bad night and still be okay the next day and feel okay. You might have a good night and still feel tired the next day. It can happen. And we also might do some cognitive work around excessive worrying. So we might do things like worry time, where you're essentially 20 minutes every single night or earlier in the day, you're kind of letting yourself worry. So you're containing it into a certain area of the day, not letting yourself worry 24/7, but you're having a specific time. We might do things like meditation. So meditation is not like a standard in CBT-I, but it's becoming that. So meditation, I'll have people meditate, but 5 minutes during the day, not at night. So meditating during the day helps you to be able to let go of things better. You're stronger. So then at night, you can let go of things better. It's not about doing an app or something to fall asleep to, which is what most people use them for. You're not getting the workout for your brain by falling asleep to it. Do it during the day and it'll be easier to like kind of retrain the brain.
Right. And I think people really don't understand that, people will say to me all the time, like, I'm just not good at meditation.
Yes.
It's sort of like, wait a second, like, that's the point. The point is, right, with meditation is that it's a training, right? It's always a practice. They call it a practice, right? And I was a non-believer. I was sort of like, oh, that's hokey. That's until I started doing it, until I had my patients do it, and I got it more because it was just sort of like, it's training your brain to get back into the present moment, right?
Yeah.
To focus on something like your breathing or counting, like,
Yeah.
and just sort of like being in the moment. But that you don't do it when you're stressed or anxious because it's not going to work. You have to do it beforehand, right?
People are always just doing it right at bedtime,
Yep.
A, in a way to try and hypnotize themselves, which is not the same thing. Or B, they're doing it at a time, or and B, they're doing it at a time when they're heightened, the stakes are so much higher because it's like, I have to fall asleep with this. It's like, good luck with that. But I think the thing with meditation too is like, sure, we in our research, my colleague, if you're interested in learning more, Jason Ong, he's done a lot of work in this. He's really the one who spearheaded it. 5 minutes a day. That's it. And people overthink it. It's really just every time your mind wanders, which is what's going to happen, it's the bringing it back,
Yep.
constantly bringing it back. That's the work. It's not focusing the whole time. And I also think people overthink what meditation is supposed to be. There's no one right way with what the apps are great because it just gives you something artificial to focus on. When I started meditating in graduate school, they were just starting to talk about it at that time. I was like, I was kind of a non-believer too. I mean, this is 25 years ago, but I had this long day at Einstein and we had a break in the middle of the day at Yeshiva, and I would go and get my nails done every week. And I noticed I never focused on the massage that they gave me on my hands. And one day I found, because I would always be thinking about the tests I had, I just started to focus on the pressure and the tension, the kind of feeling of it. And that's a meditation. For me now, I look out the window every single morning if it's light enough out. I observe and describe what I see on the trees for 5 minutes. And if my brain goes to, is there ice on there? Does that mean that they're going to cancel school? What's going to happen? Nope. Back to observing and describing. It doesn't have to be complicated.
Exactly. It doesn't have to be perfect, right? And I think
No.
right, like women usually are such perfectionists, right? And I think that's part of it. Like, I'm going to do it. I'm going to do it really well. I'm going to go all in, and I'm going to, when meanwhile it's 5 minutes. I actually really like the person who got me going on this was Dan Harris, because he's such a stick, and so his podcast 10% Happier, and he has all these great people on there, and so I feel like I learned so much from it. And
it's so true. And his book is the book that I usually recommend to most people who I know, because it's like meditation for fidgety skeptics. Like, it's like the perfect, it's a really great book if you're just not sure about meditation. And I think until him, mindfulness meditation had a real like marketing issue, and they still don't really market it the right way. It's like, it makes people not want to use it with the way it's talked about. It's
right, because it's kind of like woo woo, right? I think he used that term, right? Woo woo, right? It's sort of like, and so, yeah, so we encourage people to do that, because it is about just training the brain to go back into the present moment. Because I think what happens is, and I think this is sort of continuing on the cognitive piece, right, is there's all those what ifs, like, what if this happens, and what if this happens, and what if I can't sleep? And that pressure to sleep, right, is what keeps you from sleeping, right? And I noticed that when I worked with women with postpartum depression and anxiety, right? And of course, you're not sleeping. Sleep is a huge issue in postpartum women. And they would come to me and they'd be like, "Oh my gosh, I can't sleep. I can't sleep." And there was such anxiety about the sleep that was the issue, right? And I think that's what we're talking about, right?
And the anxiety, what it's doing, remember, for most of us, anxiety is a way to try and control what feels out of control.
Mm-hmm.
Right? So we're putting effort into something essentially that really doesn't require effort. So effort is the enemy of sleep.
Yep.
And if you're ever someone that used to not have insomnia and now you have insomnia, think about back when you used to not have insomnia. Did you ever really think about sleep at night? Did you line things up in order? No, it's that worry about it that's the problem.
Yep. Yep. And that's a really hard thing. It's just like with anxiety, right? Like, so it's a really difficult concept, right? Because part of treating anxiety is accepting anxiety and not trying to fight it. So like
Yeah.
I always talk to people, like the more you're fighting panic, the worse it's going to be. So you have to kind of like let it roll over you, kind of like you have to ride the wave. And
Yeah.
so I imagine it's something like that too, right? That's what you're talking about.
Exactly. 100%. And then also another strategy in cognitive therapy is like what you're saying with the what ifs. Another strategy we'll use is just cognitive restructuring, right? Sometimes it can be something like that where it's okay, instead of saying, what if I don't sleep tonight? It's like, what is it that's actually, if the answer was, I'll be fine, everything's going to be fine, you wouldn't feel anxious, right? You wouldn't be fearing it. So there's probably something behind it that you're worried about. What if I don't sleep tonight? I probably won't be able to function tomorrow. And what does that mean? I'm not going to do as well at work. I'm going to be more irritable with my kids. Really challenge how often that actually happens. Is it all or nothing? Or is it
Mhm.
somewhere in the middle? Usually we can get some work done. It might not be perfect, but we can get something done because at night that rational part of your brain is not working as well. So to really try and rationally think about it will be very useful.
Mhm. Any other like cognitive strategies that you use?
Yeah, I mean, there are a lot that are out there and they're kind of like, shall I say, like hacks that people talk about. So like, oh my gosh, why am I blanking on the name of it? Of course.
Okay.
It's focusing on one letter. Oh my gosh, it's on the top of my head. See, even when you sleep
See?
well the night before, you can still forget
That's right.
something the next
Exactly.
day. Um, yeah,
I
but
think I know
going
what you're
through the letters of the alphabet. Oh my gosh, I was literally just in a New York Times article.
we all do it. We all do it. It's like, well, explain it instead of the name, just explain it.
Instead of the name, it's about finding something where you're going through the letters of the alphabet. And sometimes it's like you can choose a category. That to me would be very challenging and I would be more frustrated. So you could be like A, apple, B, banana, C, cantaloupe, or you could just come up with any word you want for that letter. And by doing that, it helps to, it's cognitively engaging enough that it keeps you away from worrying and thinking about all the other stuff, but it's boring enough that you could still fall asleep while doing it.
Mhm.
So that, the counting backwards, visualization, any of that stuff.
Well, counting sheep, right? I know as a kid, that's what we learned about was counting sheep, right? Like sort of like that,
Yeah,
that was the cognitive strategy.
yeah. And there's actually research on it that shows that counting sheep can be useful. Are these things necessarily like complete evidence-based things for insomnia? No, but I always look at it as within the CBT-I framework, right? What limiting the time in bed, getting out of bed, the basic sleep hygiene, maybe working on worries. All these other strategies, meditation can help, they can all help as like tools in a tool belt. Some nights one thing will work better than another, but you have all these things to fall back on because a lot of times people are just kind of grasping at straws most of the time without having like that real tool belt to rely on.
Mhm. And that you have to kind of like see what works for you, right? Like it's
Yes.
like not every like one person might say like, oh, I did this and this worked, but some
Yes.
people's brains are different, right? So
Yeah.
like, that cognitive strategy might be different. So someone might do what you were saying about A is apple. Other people, like
Yes.
one of the skills I do for anxiety is counting like 5 4 3 2 1 0 4
Yes.
3 2, and again,
Exactly.
it's sort of like what it's doing is right. It's all it is like it's putting other thoughts in that are
Yes.
more structured and focus on the here and now, that you have to focus on something
Exactly.
else besides those like what ifs, what ifs, catastrophizing.
I just looked up the techniques, cognitive shuffling.
It was right there.
It's right there. So yeah, so there's a lot of stuff on that online too. But it's like these are all like honestly, a lot of the interviews I do for like the news are like hack sort of stuff. They want me to comment on a hack. Some of the hacks are great, some of them, but don't put all your weight in every single thing. They're just tools.
One thing that I've done with my patients is,
Yeah.
at least when I was working at the Motherhood Center, when I was working with postpartum women, is to take the pressure off. And I would say to them, you know what, just rest your eyes.
Yes.
So what
So
is that like is that a,
so that is a So when people talk about the getting out of bed if you can't sleep, right?
Mhm.
That's the idea of like, don't want to teach yourself that rest in bed, that it's still a wakefulness activity. The old school, real hardcore people who do CBTI are like, don't do resting in bed. I modify it. If I feel someone has a lot of pressure they're putting on themselves and like sleep is the goal, I'm actually okay. I want someone to be okay with being in bed without feeling anxiety. So rest is okay. There's a whole newer model of insomnia treatment called ACT therapy, acceptance and commitment therapy for insomnia. And they don't do that stimulus control getting out of bed thing really at all. It's really about being okay with just being in your bed and resting. So it's about what provider you're working with and how much they're willing to kind of change it for the person. But I'm okay with like I don't want them to feel pressure, right? A lot of times there's just this, I have to sleep. And then one other technique, which doesn't get talked about either all that often, and it's not used that much, but it's called paradoxical insomnia. And so what that is or paradoxical intention, sorry, not insomnia. So what that is when you get in bed, you do the exact opposite thing. So you lie in bed and you say, I'm not going to sleep tonight. I'm not going
Mm,
to sleep tonight. I'm just going to stay awake. And usually, because you're taking that pressure off yourself to
yep,
sleep, that you end up falling asleep.
that's so interesting.
Yeah,
That's so interesting. Would you call that opposite action or like, because
a little bit. Yeah, in like a DBT kind of way,
way,
maybe a
right?
little bit, but
But it's kind of tricking the brain, I guess. It's sort of tricking, it's
exactly.
taking the pressure off because the pressure is what makes it hard to sleep.
Yes. So, like, if you're someone who might not have necessarily an entrenched insomnia, but you have a lot of pressure and you're very rigid, like, this is what I'm seeing more and more is like a lot of rigidity around sleep and this, I have to sleep. So, I've got to make time for it and all this stuff. Then I encourage people to, like, maybe once in a while, stay up a little bit later, force yourself to do some of these other things. Maybe play around with your routine so it gets a little bit more fluid for you.
Got it. The aura ring. Talk to me about that.
It's the bane of my existence. So, any of the trackers, if you have insomnia, much of the time it actually, we call it, we have like research that's actually looking at it worsening insomnia for people because you're hyper focused on the data. And really, insomnia is not about a certain amount of minutes of sleep at night or not. It's about what you perceive as happening.
Mm,
So if you find that you're really focused on the data and it's not actually changing what you're doing, I mean, do you really need something to tell you not to drink alcohol 3 hours before bed? Most of us know it's not going to be good for our sleep. Then I encourage you to get rid of it. If you have a significant other or some, or even yourself, that it doesn't really change the pressure one way or the other. It's just like, oh, you don't make sleep a priority, let's say, then fine, use it. But the one thing to also keep in mind is that the tracking of the sleep staging is not always so accurate. It's getting better. But a lot of people, I get more and more questions now on my Instagram of like people like, what about if I only get this percent of deep sleep versus REM sleep? For decades we practice without knowing that stuff. Go by how you feel during the day. That's the key. You don't need a tracker to tell you because if you feel good, but then a tracker says you didn't sleep well last night, you're going to start focusing on what the tracker is and let that guide how your day goes.
it's really just about like, again, sort of with working with people with anxiety, depression. It's the checking, right? It's reassurance seeking. It's doing these sort of compulsive behaviors that actually make anxiety worse. And
Yes.
so think about like a baby monitor. People are like, oh, I got to have the baby monitor, right? And it went from like a baby monitor to like video monitors to and they're checking and checking and checking and checking and checking. And then you're so much more anxious about the baby, right?
Your hyper
Same thing,
arousal.
right? It's sort of like you're like checking and you're like, okay, how much sleep did I get? How much sleep did I get? Okay, it wasn't good and I have to do better. And
And remember that a lot of these things, even like the fancy mattresses that have the tracking in it. I have some patients that will send me their data, yeah, like 8 sleep, all that sort of stuff. They have all this info in it. I have patients with insomnia, they'll show me the stuff that it'll tell them for recommendations. All it is sleep hygiene that's meant for people who are generally good sleepers, but not making it a priority in their lives. I would argue if you're on this talk today, you're probably making sleep a priority in your life, that the typical sleep hygiene stuff is not actually going to improve your sleep either anyway. So it's just going to make you more anxious.
Mhm. Okay. All right, we're going to get to questions in a minute. Let's see what other questions we have here. Oh, I think I just lost it. We talked about comorbidity. Do you want to just talk a little bit more about that? Is there anything to look out for?
So I think if you're for other sleep disorders necessarily, or
Yeah, like you talked earlier about comorbidities. Like what do you mean by that?
Okay. So when it comes to insomnia, one of the things that we see really routinely, like I was saying, was sleep apnea. And what we call that's not a diagnostic category, but we call it COMISA, comorbid, co-occurring insomnia and sleep apnea. So even if your insomnia gets better, a lot of people will like take a sleep aid, let's say, or even do CBT-I, but they still feel like their sleep is not restorative. There might be sleep apnea going on. So definitely get that looked at. Like I was saying earlier, if you find that your legs or your arms or your trunk are getting in the way of you being able to fall asleep, definitely look into that. Anxiety and depression are the other really common things, and those are comorbidities, right? That are going on at the same time as insomnia. Sometimes it's a chicken and the egg kind of thing. It's hard to say which one started the other. But that doesn't necessarily, in most cases, mean that you then don't work on the sleep. So they're comorbidities. They're occurring at the same time. Maybe one started the other. But what I was talking about with a lot of the CBT-I stuff is you're changing your timing in bed. You're changing the way you're thinking about sleep. That we do separately from an anxiety and depression treatment. And what we find is if you actually work on the depression and anxiety, or sorry, the sleep first, even if you don't work on the depression and anxiety yet, guess what? It can help with the outcomes for the depression and anxiety. Just think of how um, just stabilizing a factor good sleep is.
Yep.
And if you're sleeping better, it's going to help all the other things. So I would argue, a lot of people see me as like I see them separately when they have their therapist. Some
Mhm.
people see me and they're not sure whether they should start one therapy or another. It's like, let's just do a dedicated 6 sessions to CBT-I and then go from there. And hopefully you'll get faster gains.
Right, because when we work with somebody with anxiety and depression, the first thing we talk about is sleeping and eating, right? Those are the sort of like it's neurovegetative symptoms, right? And if you're not sleeping, you can't, there's nothing else, you have to work on sleep first, right? And
Yep.
again, not to put the pressure on that's right, that's interesting,
Yeah,
right?
yeah,
Sort of like here I said something like you've got to work on sleep, right? That
yeah.
pressure, but you have to sleep generally well enough.
Yeah. And the thing that I'll often say too is like, it's a good thing you're here, right? Like, because I get all the referrals now if people are like, I have to sleep or otherwise I'm going to get Alzheimer's, all these things. Well, first of all, it's not set in stone at all. And there are plenty of people who are good sleepers that still have cognitive issues, but it's a good thing you're here and you're working on it. So let's just like table the worries and let's just you're controlling what you can. And we're working on it as best we can.
Right. And then finally, medication. So talk just overview of sleep medication and how do you work with somebody who's already on sleep medication? I know you talked
Yeah,
about
so we have all different types of sleep medications that are out there. I don't prescribe myself, but I work with it day in and day out. So we have, there's the classic kind of benzos that we think about when people think about like Xanax and Klonopin and Ativan. Those are really not the best sleep aids in general for insomnia because what it tends to do is you might feel worse the next day, have balance issues as you get older, memory issues, but also some of them are short acting like Xanax and you might have more wake ups in the middle of the night and then just have problems. Then we have the newer benzo, which are not physically addictive in the same way, like Ambien, Lunesta, Sonata. Those are the newer ones. And those can be effective for some people. We still think about cognitive issues, balance issues, long term. And then there's a newer class of medications, DORAs, so Belsomra, Qvivic, Dayvigo. Those are newer ones that can be tough to get approved by insurance a lot of times because they want to show that you've tried everything else. But they can be effective for some people too, but similar concerns. And then there's all these off-label sort of things like trazodone, amitriptyline, or Elavil, like the ones that are effective. So it's really a conversation to have with your physician. But what we always really try to do, and then also thinking about hormone replacement or hormone therapy, anything like that. But then what we really try to do is CBT-I first. We want to start there. And if you're on medication and you want to get off your medication or lower the dosage of medication or just sleep better on the medication because they don't work great for everyone, then see someone. I encourage people more so to work with a provider who really has experience with it because we can really tailor the treatment to you and understand the intricacies versus like a package deal or the apps are okay, but they're really not going to tailor it to whatever medications you're on. Same thing, like even over the counter, like people are getting like THC gummies, all that sort of stuff. Really work with someone who can help you so you can taper off of it in a safe way while also improving your sleep and getting skills at the same time.
Okay. So I mean, I've heard mostly about like trazodone that people are taking and what about gabapentin?
Oh, gabapentin. I always forget. It's like everyone's talking about gabapentin now, which is so funny. I didn't see it prescribed all that often just for insomnia, but people are now. I mean, it's another option. It definitely is. It just a lot of times these meds can also cause like a daytime sedation. And I see that a lot with trazodone and gabapentin, and depending on the dosage you're taking. So it's like, I always am like, well, okay, you're sleeping at night, but at what cost? Are you
Right.
feeling exhausted during the day? But it's an option. Gabapentin's an option if you have restless leg and you're moving your legs a lot at night. So it's an option
And
there.
gabapentin as a low dose can also help with hot flashes as well.
Oh yeah, yeah, for sure.
So that's sort
It's
of like
like
a,
for sure. It's like it's thinking about the dosage. I just see people getting like upping and upping and upping the dosage over time, and then they're just feeling crummy the next day. But it can
in
be
some ways, right? Medication should be like a short-term thing, maybe, right? Like to sort of help people get back on, or like,
yes, but if you have like periodic leg movements, which are kicking throughout the night, which are very, very common when you have restless leg, then gabapentin is actually like that or iron, supplementing with iron. But if that's not an issue, then that's actually the treatment. And like it's figuring out the risks and benefits. And if you get better quality sleep because you're on gabapentin, then so be it. But we really try not to go there first if we don't have to.
okay, we're going to get to questions. Thoughts on magnesium and melatonin?
So magnesium, they're two different, first of all, they're two different things. They're not regulated in the US. So that's one thing I always say. So it's kind of a little bit of buyer beware. Go to something that's like ideally NSF or USP verified. Those will have like a little, like kind of not stamp, but a little label on it, which shows that a third party group has actually looked at it to show, okay, what's in the bottle is actually there. So magnesium is more of a medication, a supplement that's more to chill you out than anything. So if you're feeling anxious before bed, a lot of anxiety, it's going to relax you, but it's not a sleep aid. Melatonin is, we use it in sleep medicine. We use it for certain things, but people mostly use it wrong. So when it's marketed, people are taking I see 10 milligrams on the shelves all the time. There's no evidence showing 10 milligrams is ever necessary. So about 3 milligrams or less, typically, I mean, I use tiny doses in milligram, half a milligram with people, is effective, but it's more effective for shifting of your sleep. So jet lag, if you're a night owl, but can sleep 7, 8 hours, but it's on a later schedule, certain like acting out in your sleep issues will use melatonin to change your sleep timing. But for insomnia, not the most effective. Some people swear by it, but generally it's not that effective.
Got it. Okay, so another question for all of us who wake up at 3 a.m. every day due to hormones, not apnea, what is the rate of effectiveness of CBT?
Very effective. So it depends upon the person, but the rates typically are about 65 to 70%, which just across the board. And even if it's hormonally driven, we don't know why necessarily, but CBT really does help. It can help with hot flashes because ideally because you're deepening the sleep probably. But yeah, I mean, it doesn't work for everyone, but neither do the sleep aids or hormone therapy. So, but it's a really good treatment.
Okay, next question. As we get older, don't we also need less sleep than our early years? If so, is waking earlier, like an hour than normal, not always bad?
You don't, that's a misnomer. So you don't typically sleep a lot less as you get older. You might sleep like maybe a half hour. What changes is that people nap during the day more. So if you look at a 24-hour period, it's actually the same amount of sleep. What changes is the depth of the sleep and it gets more broken. So you don't have as like that kind of knocked out deep, deep sleep. It's more broken throughout the night because they're usually having to use the bathroom more, pain issues, things like that. But you should, if you're sleeping an hour, 2 hours or more less than you used to, definitely get that evaluated. And if someone tells you that's totally normal, find a different doctor.
Okay. You're the best at answering questions. I just want to let you know. You're like quick
Oh,
and to the point.
good.
I love it.
Sometimes I feel like all I do is like
No,
this.
no, 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 no. We always have something. We always want to answer questions. So, okay.
Yes.
So many people talk about getting enough protein. How does protein impact getting a good night's sleep?
So protein is helpful to some extent. So I'll tell everyone what I do. So what we find, protein in of itself is not necessarily like a sleep aid, but it can help with kind of relaxing you into sleep. You want to also be careful what kind of protein you're eating because people will have like really high fat things or like things that will cause more indigestion. So you want to think about that, but it's the mix of protein and carbohydrates that's actually the thing that can help be more sleep supportive overall. So what I do most nights, I do one of two things. I will have Greek yogurt because that has a good amount of protein. And I have non-fat Greek yogurt that's plain. And then I add in some whole grain granola into it, low sugar granola. So I get the mix of the carbs and the granola, the carbs and then the protein. And that can be enough to keep you satiated and then also help with the sleep inducing. And then sometimes I'll have like a protein shake, like no endorsement from them, but like Core Power, like I like their chocolate. I drink that as like a hot chocolate. I warm it up at night. So I'll do that with maybe a little granola, something like that, just in the winter because it's calming. But yeah, I don't think about like high amounts of protein to help you sleep. It's that mix between the two. And even an hour before bed, a little snack can be really helpful.
Right. Okay, good. All right, next question. Thinking about lifestyle, how we eat and move throughout the day, how does that impact insomnia?
So eating, if you want to think about, right, higher fat foods. I mean, heartburn is really, I get it. Like I'll like be so mad if I had a piece of pizza too late, or chocolate, whatever, it'll hit me. So you want to think about those kind of foods, higher fat foods, limit big meals within 3 hours of bed, but a little snack for many people's okay. And then when we're thinking about movement, right? So sleep at night is a battery that's recharging. If you're not using it during the day, it doesn't need to recharge as much. So be mindful if you're sitting at a desk trying to get some movement, trying to get some light exposure. It doesn't have to be anything excessive, but then try to get about 20 minutes of getting your like a little bit more vigorous movement. So 20 minutes of getting your heart rate up a little bit. It could be strength training even, it can be aerobic exercise, it doesn't matter. Just try not to do really vigorous exercise within 3 hours of bed. So earlier in the day, even 4 to 6 hours before bed can be helpful, but really make sure to get some movement in.
Great. Okay, next question. What about fatigue not caused by lack of sleep? Is there some other aspects of perimenopause that causes energy issues?
Well, could be the hormonal changes that just are causing fatigue anyways. But then the other really big one is sleep apnea or periodic leg movements in the middle of the night. But sleep apnea is so common. And if you just feel like you're, even though you're sleeping at night, but it's not restorative, definitely get that looked at. And a lot of people will not, women especially, won't be taking naps or dozing, but they just feel like they have nothing in the tank. That's when I would get it evaluated.
And also get a full panel blood work, right? Get a
For sure.
full panel, get
For sure.
find out about your thyroid, find out if there's anything going on, look at, vitamin D, look at B vitamins a little bit. You know what I mean? Like just sort of like
Exactly. So many things, right? And like just like even
iodine.
iodine, iron, right? If you're noticing you're having restless leg, the first thing we always think about is like, how is your iron? So like something like that can just be a little bit of an issue.
Interestingly, just a little personal information. So when I went on aromatase, I had breast cancer and aromatase inhibitor. I was so tired, and it turned out that I was low in iodine. And salt now, a lot of salt does not have iodine in it. And
Yeah.
remember on that package, it's like a necessary nutrient.
Yep.
So I started taking a little bit of iodine supplements, and then I started doing more seaweed and just getting in there, and I started to feel a lot better.
Well,
So
so good.
yeah.
Good.
Okay, what can you do about restless leg, as you mentioned earlier?
So first thing we always try to do, and I have restless, full disclosure too, I have restless leg and periodic limb, like really bad. I've had it for many years.
Hmm.
The first thing I always try to do is look at sleep hygiene and making sure that you're not having excessive caffeine, like a cup or two of coffee earlier in the day is fine. Alcohol use at night, making sure you're hydrated, you're consistent with your sleep wake timing. Those are the initial things to think about. Then you want to think about any other triggers. So for me, I'm a marathon runner. So when I'm actually doing really long runs, my restless leg is like, I know it's going to not be great.
Right.
So, are there certain types of workouts, walks that are worsening it for you that you can kind of be ahead of a little bit? And then, if that's not enough, then we look at, like you were talking about, looking at ferritin levels with like blood tests. So, we'll look at ferritin levels for a lot of people. And if that's low, even it doesn't, I forget the cutoff. Just because I don't diagnose it myself, but a lot of times the cutoffs of where people will say you have low iron versus what actually might cause RLS is not the same. So you could still have within normal limits be on the lower end and still have restless leg and be considered lower that you have to get that supplemented with iron. So you want to get that checked. If that's not enough, then we might look at, we have different medications, gabapentin, pregabalin, we have different ones out there that are options if it's really causing issues for you.
Right. Okay. Another question. I don't have issues falling asleep, but frequently wake up at 2 or 3 a.m. due to night sweats, et cetera, that trigger anxiety. What helps with that?
So, like I've been saying a lot, just make sure that apnea is not an issue if you're having sweats a lot. Make sure your room is cool and really like keep it nice and cold. I go to bed with a really cold room and I wear socks. So that's another thing. Also, if you always notice that you're waking up around the same time, maybe like try not to look, if it's not necessarily, if it's sweating, that's one thing like that. You really need to think about sweat wicking sheets, pajamas, while also getting evaluated medically. Um, but you want to also think about not looking at the clock because sometimes we might also exacerbate the anxiety. And we all wake up at night. Everyone wakes up 4 to 7 times. Everyone. We just sometimes notice it more than others if we're looking at the clock. And then also some of the newer technology, it's cost prohibitive for a lot of people, but like, and I don't get paid by them, but like the 8 Sleep, the Ooler, there's all these different mattress cooling products out there that for some people who have real temperature regulation issues, it can be a game changer.
Mhm. And then treatments for the hot flashes, right? So,
Yeah. Yes.
menopause hormone therapy systemic is the gold standard of
Yep.
treatment. Um, but if you don't want to do that, or you can't do that, there is a new treatment called fezolinetant,
Mhm.
and that is now we know why women have hot flashes. We never knew why before, and so that is a treatment for hot flashes. So
Exactly.
that's a thing.
So if the hot flash is happening, definitely get that evaluated. But always get a if you haven't been medically evaluated, just get it medically evaluated for sure. And then you can work on the other stuff too. And then also things like alcohol, caffeine, like those are all things that can worsen that stuff as well.
And keeping the room cool. Like I know, I mean, I can't take hormone therapy, and so I have flashes a lot less. But I would my poor husband, like my room is freezing. Like I'm just sort of like I'm like air conditioner, fan, like whatever it is. I cannot sleep when it's hot. So, um, okay, next question. What I find stressful when I awaken in the middle of the night or too early in the morning, trying to decide if I should get out of bed or just lay there and rest. That's interesting.
So rest in bed, not terrible, as long as for a little while. For a little while, if you're not like anxious, frustrated, it's the frustration. When you're frustrated that you're not sleeping, that's the sign you need to kind of go sit somewhere else. But I would encourage you, if you're someone who occasionally has early morning awakenings, earlier than you'd like, don't start your day routinely at that earlier time. Because, excuse me, the minute you start turning on your computer, you start doing work emails, you maybe have some coffee, you're now training your body's natural circadian rhythm to have earlier morning awakenings. So really, it's just get up. If you need to get out of bed, go sit, do something quiet, reading, calm, relaxing in another room until your alarm goes off or your kids come in or whatever it is to start your day. That's when you start your day. Obviously, get up early once in a while if you have to, but don't make it the routine to do every time.
It is just like training, kids, babies, right? It's sort of like I always say to moms, like, if you're giving them a milkshake, if you're breastfeeding or you're feeding them in the middle of the
Yep.
night, they're going to keep waking up in the middle of the night, right? It's sort of the same idea, right? Sort of like the least amount of stimulus during that time.
Yeah, and a really common thing too is a lot of people say to themselves, "Oh, I know I'm not falling asleep, but I think I might start getting sleepy, so let me just lie here." Give yourself the 5 minute rule. Like if you give yourself 5 more minutes. If you don't fall asleep in about 5-ish minutes, guesstimate, then you fooled yourself. Then get up. If you're frustrated or anxious, get up, go sit somewhere else.
Okay, great. Success of people doing CBT on their own with apps, not real-time therapists.
Pretty much about the same, believe it or not. It's really effective. It just depends on like how complicated your case is. But for a lot of people that are just trying, like even my book is a self-guided CBT-I, like there and the apps, like all those are very effective for a lot of people. We have a really good research base on them now. But if you have some of the complications, I'd recommend working with someone.
What was the name of that book and the author, the meditation book?
Oh, 10% happier, meditation for fidgety skeptics.
Yep. Do you have any view on yoga nidra? Nidra?
Um, Not really. It's like deep breathing rest kind of thing. It's like, and a lot of people will say that it can be useful, but it's not. I think it's a good thing to help get you to like kind of restore a little bit and just rest. But it's not really in and of itself a evidence-based treatment.
In talking about comorbidity, are there more studies being done about how brain aneurysms, hold on, moving, or other brain injuries affect hormones and menopause?
I can't speak so much to the hormone changes because that's not so much my area, especially when it comes to like the neuroendocrine stuff. But yeah, there is more and more research that we're doing in the field looking at just neurologic conditions and how that's impacting sleep. So like stroke and then insomnia, stroke and excessive sleepiness, any of that sort of stuff we're seeing. Headache, chronic headache and migraine, we're seeing how that can impact sleep and then coming up with like modified interventions around there.
Okay, great. Another question. I've had insomnia for over 15 years. Oh, I'm sorry. And take Ambien, Benadryl, and melatonin nightly, use sleep hygiene, meditation, and still struggle with sleep.
I would recommend trying some CBT-I on top of it. If you have to take Benadryl and what was it, melatonin on top of the Ambien's not doing what it needs to be doing. And Benadryl we do not love as a long-term sleep aid just because the cognitive issues, the falls, even more so than Ambien, believe it or not. So I would recommend CBT-I, and if that's on top of it, and if those things aren't working, then maybe having a consult for other medications.
54 years old, on hormone therapy 2 years, started waking at 4 again. New night heat flashes, question mark, skin hot at 4, high stress, could increasing the patch help on lowest dose?
Can't say for sure. That you'd have to talk with your doctor about that for sure.
Yeah. It's trial and error, right? I think that's one of the things like
Yeah.
people, have to sort of, if it was working and it's not working, maybe increase it, maybe do, again, do a CBT-I in addition, right? So I think that's sort of the. Okay, I think we have one more question left. And wow, this is amazing. As I age, I find that I fall asleep more abruptly than when I was young. Is this related to menopause? I've never heard that.
Not necessarily. No, it's like, I mean, it's just, well, okay. Let me take that back. If you fall asleep really fast every single night within 5 minutes, do you have any issues with the quality of your sleep at night, right? Is there anything like where you're having a lot of awakenings, you're not getting enough sleep routinely, like there's apnea, I don't know, I'm not diagnosing you, but is there something else that's going on? Because you don't want to fall asleep immediately when your head hits the pillow. It should take a few minutes at least. But also we're so exhausted, like I said at the beginning of this, like there's so many things that are causing us to have our demand, like that are demands for us, that you might just fall asleep faster. But if you're excessively falling asleep like in a minute every single night, maybe think about getting a little more sleep at least.
But I actually think so. My husband falls asleep literally within
Oh yeah,
within
yeah,
seconds. So some people are just like
in,
that. Some
day in
people
and
do
day
that,
out, I hear that. So
right?
yeah,
It takes me a lot longer. So yeah, thank you so much. This was
pleasure.
really incredible, Dr. Harris. Just are there any more questions? Okay, hold on. One more. What's your favorite statement to say to yourself when you awake in the middle of the night, when you wake up in the middle of the night?
Um, I would say that it's normal to have awakenings. Waking up is normal. Everyone wakes up after a sleep cycle. And then if you just are noticing one other statement saying that I love in the morning or anytime during the day, if you had a bad night of sleep, it's a mantra that my old colleague or my old mentor, Michael Perlis always says, if not tonight, then tomorrow. And if not tomorrow, definitely the third. Because usually by the third night, you have a natural ability to start catching up a little bit more if you keep those guardrails of not sleeping in and all that sort of stuff. Just most people don't let themselves get to that third night. They start getting really anxious, start taking stuff, start putting pressure on themselves, and then it backfires.
Right. This was really incredible, Dr. Harris. Seriously, like you were so, so, so good. We've already gotten comments in the questions just about how good this was. And
Oh, I'm so glad.
really just, and so people asked, is this going to be recorded? Yes. Give us a day or two. We put it up on YouTube. We have a YouTube channel, and then it's also on our website. We're also going to send everyone out a recording, send to your friends, send to everyone, get them to listen. This was really great practical advice. I know I understood a lot more about cognitive behavioral therapy for insomnia. And so thank you so, so, so much. Dr. Harris, we know you're busy, so you can leave. And we'll talk to you later. We can't wait
Bye,
to
everyone. Take care.
and for everyone else, just stay on a few more minutes. Please, we're going to launch the survey on Slido. We really love your comments, and tell us in there what else you want to know about. Our next menopause talk is on Thursday, November 20th at 1 p.m. with Dr. Kelly Casperson. So sign up, tell your friends about it. Testosterone is a hormone that we're learning a lot more about and that people are talking more about. And so this is one of the subjects that people wanted to learn more about. And so we're listening to everybody and putting on menopause talks that people want to hear about. I think that's it. And we're going to keep this up. So again, please sign up for our next menopause talk. You can visit our website at letstalkmenopause.org. Our past menopause talks, we have over 35 of them on every single subject imaginable. And so you can go to our website there. You can donate. We are a nonprofit and we always love donations. They help us continue our work. And you can also contact us at any time. So I'm gonna sign off, but we're gonna keep it on so that people can continue to take the survey. So thank you so much, everyone, and have a great rest of your week.